Hi, my name is Pauline Germaine from the Department of Radiology at Cooper University Hospital. My colleagues and I are excited to impart some radiology knowledge to you through many sessions of point-of-care ultrasound curriculum. In real life, you will have many opportunities to review lots of x-rays, and we hope that they will all be stone cold normal. Unfortunately, many of our films are not exactly normal, containing lots of tubes and lines, external wiring, and tubing, making the assessment difficult. In order to recognize the abnormals, we need to familiarize ourselves with normal appearance and placement of these tubes and lines, and we'll practice the abnormal placement during our point-of-care ultrasound sessions. So let's spend some time reviewing the normal appearance. So why do we place these tubes and lines in the first place? Injuries and/or treatment may compromise normal physiology such as breathing, eating, and hydration, and protective reflexes, and these lines and tubes help patients during the acute phases of injury and/or recovery. So here is an example of an endotracheal tube with a deflated and an inflated balloon. What is the ideal location of the endotracheal tube? Ideally, we would like it to terminate somewhere between the medial heads of the clavicles and above the carina. Or said in another way, we like it to be somewhere between 2 to 5 centimeters above the carina. This is a nice example of a well-positioned endotracheal tube terminating just below the medial heads of the clavicles and certainly above the carina. In terms of central lines, we have peripherally inserted central catheters. Here's an example of one. And we also have the central lines. And what are they used for? Ideally, they're used for administration of fluids, antibiotics, chemotherapy agents, as well as CT or MRI contrast media. However, these could be irritating to the vessels. Ideally, the central line should be positioned in the superior vena cava, or somewhere between the bottom of the azygos vein and about a centimeter below the origin of the right mainstem bronchus, as demonstrated here. Most commonly, these are malpositioned somewhere in the IVC or the right atrium, and they should course lateral to the spine normally. Some of the common complications of central line placement include malposition, pneumothorax, line kinking, venous injury resulting in hemothorax and/or mediastinal hematoma. What are some of the additional complications? They include thrombus formation, particularly if the line ends somewhere too peripherally, or if the line is too centrally positioned in the cardiac chambers, it could cause arrhythmias and/or thrombus formation. So where is this PIC? This is an example of a well-positioned PIC terminating somewhere in the superior vena cava. Can this line be used? Well, it's a trick question. I personally don't know if the line is clotted. Not sure even if this is in the patient or on top of the patient, but you hold the key to the clinical information. This is a nice example of a well-positioned central venous catheter inserted via the right internal jugular vein approach. The catheter terminates in the superior vena cava, well above the level of the cardiac chambers. And here is the outline of the catheter in the superior vena cava. Nasogastric, orogastric, and Dobhoff tubes are used a lot in clinical medicine. Here is an example of one such tube, and notice that the last port is actually perforated, and that's an important sign for us to look for on the x-rays. So here is a nice anatomy refresher as demonstrated on this small bowel follow-through. Here is the G-junction and the portions of the duodenum. Ideally, we would like the endogastric tube and/or the orogastric tube to terminate 10 centimeters past the G-junction, or the last side hole to be past the G-junction to minimize the reflux possibility. And the Dobhoff tubes, we would like to be in the gastric antrum or even descending duodenum. This is a nice example of the nasogastric tube, which terminates in the body to antrum of the stomach. Here is the outline of the catheter, which is well positioned in the stomach. This is a nice example of the Dobhoff tube. Notice that the tip of the Dobhoff tube is thicker and of higher density. It is weighted. Ideally, we would like it to be positioned in the distal stomach to duodenum to minimize the risk of the aspiration. Here is the outline of the catheter, and you can see the more distal location of the catheter. Chest tubes are placed for air and/or fluid management. If they're pointing superior, then they're usually placed for air management. If they're pointing inferior, they're usually placed for fluid management. And the last side hole of the chest tube should also be located in the pleural space. So in summary, we have looked at several common tubes and lines. Endotracheal tubes should terminate 2 to 5 centimeters above the carina, but somewhere below the medial heads of the clavicles and above the carina. The central venous catheters should terminate in the superior vena cava. They're most commonly malpositioned into the cardiac chambers and/or the inferior vena cava. The endogastric or gastric or Dalpov tube should be positioned below the G junction. Specifically, the last side port of the tube should be below the G junction to minimize the possibilities of reflux. And the chest tubes and their last side port should also be inside the pleural space. Thank you for watching, and we look forward to reviewing many cases of normals and abnormals during the practice sessions with you. Thanks.